And my final case here is discussing a patient with Stevens-Johnson syndrome. And so just prefacing the case, Stevens-Johnson syndrome is a hypersensitivity drug reaction to a medication, various different types of medication, which result in blistering of the skin, involvement in many different organs throughout the body that also include the eyes themselves. So ocular involvement of the Stevens-Johnson's can result in severe PPE, dryness, staining, to keratinization, cicatricial changes, some blepharon formation, ulcerization, perforation, very intense changes to the eyes and the eye structure, resulting in severe eye dryness. These patients have the tough time keeping their eye open, and really much their vision is affected. And so this is a 47-year-old female that I saw when I first started out at Cornell that was diagnosed with Stevens-Johnson syndrome due to presumably doxycycline reaction, resulting in severe ocular surface condition, has some blepharon formations, has several instances of persistent epithelial defects, trichiasis that resulted in electroablation therapy, often constant epilation. And then in addition, resulting with everything, she had very dense brunescent cataracts in both eyes. And so, when I started seeing her, she had been on multiple therapies with minimum symptom relief, pain, itching, redness, decrease in vision. She had been monitored in kind of a consistent therapy of using long-term use of contours for a couple months, 22 to 24 millimeters, and we would just exchange them out every few months, which resulted, for protection's sake, which was good, but still the patient wasn't able to improve their vision, and consistently had about 2200 vision. The ocular surface was so poor that the cataract surgeon and cornea specialist they were not going to do surgery on the eye at the point. So we wanted to implement scleral lenses to improve the ocular surface for cataract surgery. So this is a tool that our department uses quite a bit, that we start the fitting beforehand, before cataract surgery, to improve the surface. We eventually change things and adjust it after surgery, but at the same time, help improve the outcome of the surgery, because the chance for complications, specifically these patients, persistent epi defects, things like that, are quite high. So we want to make sure we're reducing the risk. And then afterwards, we're going to use the scleral lens for vision, protection, and comfort. So we can see here, going back actually, we can see the severe dryness, the staining, and this is prototypical staining we're going to see for these patients with Stevens-Johnson syndrome or any of those severe ocular surface conditions we were talking about. Very high diffuse punctate epithelial erosions. This is a photo of her wearing the 24 millimeter contour lens, again, providing quite a bit of comfort, or protection actually, but very uncomfortable because there would be bubble formation, there would be, just the thickness of the lens, and it was just not providing a comfortable scenario for her. So we did start the scleral lens fitting. However, due to the surface of the eye and just the severe surface, we were getting similar. This is a stock photo, but a photo nonetheless, a similar scenario of the surface poor wetting, just due to the ocular surface of her eye. And so what we did was, we know this was a time where we implemented new technology. Another example of utilizing new technology, tangible HydroPeg. HydroPeg technology allows for greater lubricity, reduction of surface deposits, and increases water retention, so reducing that poor wetting surface. And so you're going to have a slicker, smoother surface, resulting in a surface that's going to allow patients to provide consistent, happy vision regarding the front surface of the eye. And so this patient I used a Visionary Optics Europa 18 millimeter lens, another large diameter lens to provide a large surface area protection to achieve great vision. And this is a very cool story of a patient that was suffering with 20/200 vision for quite a period of time. And then we were able to improve her ocular surface to get to cataract surgery. And then after cataract surgery, achieve 20/20 vision consistently. And so patients that have these, systemic or reaction, like high inflammatory conditions on their eye, they're going to have these waxing and waning moments. So looking at this fit, it looks good to me. But you're going to look and see, there are areas of redness, injection, and there's areas that look like blanching. And so you have to really monitor these patients very closely, and you're going to monitor them very closely with cornea and feeling very comfortable and closely co-managing, because you're going to have these changes, and you have to understand when there's a change, when we need to kind of look into changing the fit or taking a break from the lens or kind of changing the treatment protocol. And so these are all things that you have to keep in mind for a lot of these patients with severe ocular surface conditions. Again, utilizing the large surface is going to be important, or large coverage, but also kind of monitoring them very closely. So overall, there's disadvantages and advantages to scleral lenses. And so we know with our advantages, we're going to get visual improvement, we're going to get comfort, we're going to provide protection and coverage with the lens, depending on the size, we're going to get lubrication, and now there's greater technology to provide customization, just from our torics to our quadrant specific, to our coatings, to our impression molding, scleral technology, all of that and then utilizing our technologies as photo documentation, anterior segment OCT, all of that put together to get a very efficient fit. That being said, there are some disadvantages where handling the lens for insertion and removal can be quite different and challenging for some patients that may have some dexterity problems. The fruiting process could be a bit longer, and that could affect specifically maybe your practice modality and how that can fit into your practice. Is that something that you're looking into? And so the other aspect is midday fogging. I know that's something that with these new technologies we're reducing, but at the end of the day, it's still going to be there. And it's hard to kind of get a good picture. And with new studies that are happening, hopefully we can get a better understanding. We are getting a better understanding, but where do we go from there? And then again, the last thing that is always discussed is cost. Scleral lenses are a bit more expensive. Again, varies if the patient has insurance coverage with medical versus vision plan, and how that plays a factor. But it can be a costly endeavor for these patients, and so you really want to talk to them about this process and kind of time with the lens. I titled this Navigating the Anterior Segment, right? So how do we get from point A to point B, and how do we get to scleral lenses, right? And so there's a lot of different regimens, and so kind of going out of order in what I've described here, but we want to exhaust our therapies. We want to make sure we're trying as many different things as possible before we get to scleral lenses, because it is quite a bit of a change for the patient. And so it's a great therapy, but at the same time, it is quite a bit of investment and time, cost, etc. So you want to try everything else possible before we get to that point. And then also, going back to the keratoconic patients, let's not forget about our corneal RGPs, our custom soft lenses, our hybrids, our post-transplant patients that we may worry about corneal edema. These are still a great option, so don't forget about those. Don't be afraid to go big with scleral lenses. And, we're hearing new things with, thin lenses, smaller diameter, again, worrying about oxygen permeability. At the same time, there's a lot of information clinically with many different groups that we can go larger as long as we're monitoring these patients well. We have to fit them properly. There's things that we have to look out for, and we have to use the latest technologies with high decay material, utilizing these technologies, just like I was saying, with surface coatings and utilizing anterior segment OCT to kind of see exactly micron value where we're at. We can be able to be more comfortable going larger. But again, we have to understand what are potential complications with all these sorts of things. And so again, I just wanted to conclude and say, there's a lot of different options out there when we're managing anterior segment, but I wanted to focus a little bit more on the scleral lens side of things and focusing primarily on keratoconus and dry eye being two that are often that we see in clinic. So that concludes my talk. Thanks for listening. And I'm gonna take some questions here shortly, but again, here's my email address. Feel free to reach out anytime if you have any questions, happy to help. And so thanks again and enjoy.